Welcome back to this three-part series on quality improvement presented on behalf of the PA chapter of the AAP and the Pennsylvania Medical Home Initiative. The Pennsylvania Medical Home Initiative is a project of the Pennsylvania Department of Health in partnership with the Pennsylvania chapter of the American Academy of Pediatrics. This is meant to be an introduction and provide you with background information so you can effectively embark on quality improvement in your practice. Part 3 and the final in our series will look at what's involved in quality improvement. Our learning objectives for this third segment are to identify what it takes to be successful at quality improvement, to understand the PDSA cycle of continuous quality improvement, and to envision what it will take to be successful in your practice. Quality improvement that is successful incorporates attention to people, processes, and technology. Key principles include systems and processes, keeping the patient and family at the center, reinforcing the team it takes to do the work, and focusing on the wise use of the data. This is a great schemata from the HRSA Quality Toolbox. That's HRSA. I encourage you to explore the tools and information that are available on their website. There has been thoughtful study of what it actually takes to improve and sustain quality, and you should not reinvent the wheel in your practice. Take advantage of tools in the public domain to educate yourself and your QI leaders in your practice. The inputs to the process are outlined above, and almost all QI projects involve the people, the infrastructure you have in place, materials, be they patient education materials, vaccines, etc., and the technology. The processes you put in place or the activities of your team include not only what's done, but how it's done. Together, the resources and the activities are what drive your results. Most of you should be familiar with this plan, do, study, act of the PDSA cycle of quality improvement. True QI cannot be accomplished without all 4 phases of this process. Planning without acting rarely results in improvement. I always plan to exercise to lose weight, but somehow when I don't find the time to make it happen, I shouldn't be surprised there's no improvement. If you have your plan translate to action, you really need to study what happens. If you're not looping back to assess the effects of what you've done, you may have a false sense of improvement or may have made things worse. I want to bring your attention to the act portion of this cycle. Notice that the default isn't always to widely adopt the plan you began with. Most times there are needs to adjust your original plan as you gain more information, or sometimes there's unintended consequences. This should be an iterative process and not one trip around the circle. I cannot stress enough the willingness to abandon a plan that simply isn't working the way you expected. This is very difficult to do when you've invested a large amount of time and energy. However, sometimes the timing isn't right, sometimes you need different perspectives, sometimes you don't have the right technology and you need to regroup. Sometimes additional training is needed. It's okay to abandon a plan that is not having the desired outcomes. You didn't fail. In many cases, you learned something very valuable that you can incorporate later. An example in my practice of a project which didn't work out as planned was our ADHD follow-up project. Doctors noticed we were refilling ADD meds for patients who hadn't been seen in a while, for our colleagues who were not in the office that day for one reason or another. Sometimes meds were being refilled for patients who hadn't been in over 6 months. Sometimes we would refuse to refill the prescription until they made a follow-up appointment. But the doctor who usually saw them felt like they were stable and didn't need to be seen every 3 months. We started a project where the person who saw the patient would write a task in the electronic health record for the appropriate follow-up visit. But this fell apart when doctors forgot to do it, or parents said they would call back when they had their calendar in front of them. In addition, the report which we could get out of the EHR didn't really reflect what we were trying to accomplish. And there wasn't actually agreement among the doctors on how often to see the patients back. We abandoned the project. We're going to regroup this fall using some care plan functionality in our EHR and start first with a discussion about who should be seen and when and how often. In the meantime, we've incorporated electronic prescribing of controlled substances in our workflow, and we're trying to figure out how to document checking the state controlled substance database as part of that process. Stay tuned for how this plays out. Many practices get in the habit of doing things in a certain way because they always have. If you are truly going to improve quality, you need to carefully reflect on your ability to meet your patients' needs and their expectations. You may be doing a great job of not giving antibiotics for URIs, but if your parents expect to leave with a prescription, they may not have a satisfactory experience. Do you then need an educational campaign on the appropriate use of antibiotics for your patients? What would that look like in your practice? Gone are the days when you can just take care of the patients who show up at your office for care. You should also be proactively reaching out to all of the patients who are attributable to your practice and get them in to receive appropriate services. There are certainly challenges in trying to find differences in what you think your active patient list is and what the payers do, but you must start with having a process to maintain your active patient lists so you're internally consistent. Involving patients and families in the process can be eye-opening. In my practice, we were going to add more evening physicals, but our mothers with young children told us that they would prefer early AM appointments and just drop their kids off at daycare a bit late and then head to work, rather than trying to reverse engineer the end of their workday with a cranky toddler in their car. Okay, it's time to admit that we can't individually do this work. We need to make teams that include all roles in our office. We also need to empower those teams to speak up, problem solve, and give our team members training and education to execute our plans. As practice leaders, we can decide that all missed appointments need to be followed up on and develop a protocol. But if we aren't actually doing that work, we need to listen to the folks who are doing it and get their input if we're going to succeed. We also need to understand that all patients don't need the same comprehensive team. Some patients' effective team members may not even work in our practice, like a social worker or a school nurse or a teacher for a particular patient. I encourage everyone to read the new team-based care policy statement from the National American Academy of Pediatrics. Data really is the key to practice empowerment. Having a way to see measured performance can be eye-opening. Most practices say, "This can't be my data." We tend to have a positive reflective memory and selectively forget the times where we made an exception or something didn't happen the way we knew it should. For example, our practice really thought we were good at writing generic medications for ADD. Then we ran the report. The report gave us actionable data. We could check the patients, see what each of us wrote, and lo and behold, we were writing more name brands than we thought. Why does this matter? In many cases, it's both a higher cost for the family, and most people have tiered copays based on formulary or generic prescribing, and the payer has a higher cost. You may think that that doesn't matter to us, but it should. Payers are painting profiles regarding the total cost of care. And in the eastern part of the state, we're actually getting bonus pay for performance dollars for keeping down the total cost of care and for generic prescribing. Two different buckets of money we can gain if we're good at this. Once you have a baseline, and you can do a root cause analysis to identify where and why gaps in performance happened, then you can develop your plan to improve and prioritize it. You can also then compare different office sites, your colleagues, provider to provider, use the information to work collaboratively to raise everyone's performance. Once you're a rock star, you have to make sure you don't slip and continue to monitor your data. Make sure you adopt, adjust, or abandon as needed. There is value in collecting feedback to see how you are doing. This can be a rating survey or simply comments. I encourage folks to not only measure qualitatively how you are doing with your patients, but also your practice team. Where do they see additional room for improvement? Are they struggling to make the plan work? Do they have a suggestion? It's also very helpful to sometimes be an observer. Be a fly on the wall. Follow a patient from your front desk to the exam room and back out. Did you deliver the way you strove to? Is there room for improvement? Don't use that information in a punitive way, but in a way that you can continue to improve. For data to be as valuable as possible, it needs to be clear and actionable. For every metric you submit information or query you run, you should know exactly what the numerators and denominators are. If you're trying to determine what percentage of your active patients had a well visit in the calendar year, how is active patient defined? Is it any patient who has an active status flag on the patient register? Is it any patient who has been seen at least once in the past 3 years? You also need to harmonize what you think is the right way to define the denominator and how the information is actually getting pulled from your EHR or practice management system, or from the payer. What does it mean calendar year? Is it starting from today and looking back 365 days? The payer's likely defining it as any time from January 1 of the calendar year to December 31st of that same calendar year. Can your system replicate the query the payer's using? In most cases, the payer is getting everything from claims data, and you have more accurate information in your system. However, you need to negotiate with the payer an opportunity to provide additional information. Great example. For QI measures involving vaccination rates, what do you do with families that refuse specific vaccines? Will the payer allow you to submit additional supportive information, such as an AAP standard vaccine refusal form with a signature, in order to have those patients be included in their numerator? Someone should understand the data mapping in your system so you know where information is being pulled from in various reports. For example, if you're doing a QI project to improve follow-up on newborn screens, where's the query coming from? If you have the result in a scanned record, but it doesn't have the correct label, the computer may not count that scanned record. Many times scanned documents can't be counted in an electronic query because it's really just a picture, which a computer can't read. Do you also need to check a box or put an entry in a discrete data field for newborn screen reviewed in order for it to be counted? If so, who's going to be responsible for doing that? Actionable data is key. If you can identify with that query the patients that didn't get services, then go look at their charts and find out why. Did they no-show for an appointment and no one ever contacted them to reschedule? Are they really not active patients and moved 6 months ago? In order to begin to figure out how to improve, you need a clear understanding of why your baseline performance is what it is. In order to lead, you need to feel a common mission. Does your practice have a vision or mission statement? Is it shared by the entire practice? We know that our patients perform best if there is clear expectation setting and continual reinforcement. No setting is more difficult to improve than when not all the leaders are on the same page. How is the rest of the team supposed to know what to do if one doctor is recommending HPV vaccine at age 11 routinely, and another is telling parents it's okay to wait until high school? Some providers may need training on how to manage conflict and on shared decision-making with families. Some team members may need new skills. Empower everyone to work to their fullest potential, to speak freely when they are identifying barriers, and to work collaboratively with others to problem solve. A great leader makes sure all of this happens and works to make sure that communication not only happens, but it's effective. Posting notices that say, from now on, everyone must offer HPV vaccines at age 11 or get a refusal form signed, is not really likely to actually improve your HPV immunization rates in your practice. When you embark on quality improvement, it's essential that your entire practice team is bought in and brought along. If you have reluctant team members, identify their obstacles and work to overcome them. If they refuse to be part of a particular project, consider getting them on board something that they can feel good about. Everyone that is a key stakeholder in the improvement process must have a clear understanding of why you are doing it and believe in the project plan. It's not enough to have a kickoff meeting and get everyone psyched. You actually have to monitor that the buy-in is sustained and find ways along the way to support it. Consider setting short-term goals and having a practice ice cream party to celebrate your mini goals when you achieve them. Set yourself up for success. Especially in the beginning, set small goals that are realistically attainable so the team can feel good about their work. This slide says it all. We are always a work in progress. There is always something more we can do or another project to improve. But celebrate those small successes. Don't talk about failure. Talk about barriers to success. What got in the way, why, and how can we learn from it? Even if you get to what you think is the highest possible goal, Keep monitoring it and be mindful of thanking folks for the work that they are doing to sustain the achievement. Now that you're getting excited about QI, remember that doing too much at one time is exhausting and can even result in compromise in patient safety. Change should be paced, manageable, and it's okay to take a breather for a while if you have done some great work. Encourage team members to think outside the box. Some of your youngest or newest staff may have some of the best ideas. Some of it may come from when they trained, and they were thinking to themselves, why in the world do they do it this way? Encourage everyone to suggest ideas for QI projects. If the front desk thinks there has to be a better way to deal with getting HIPAA consents, let them suggest a project and brainstorm the solutions. They have to do the work, and if they are more efficient, they have an extra moment to smile at the parent and notice that the sibling has an outstanding balance on their account. Everyone can win when the entire team has a continuous improvement mindset. This concludes the third and final in the three-part series on quality improvement. We're excited that you have come on this journey with us to understand what is needed to create a successful quality improvement program in your office. We hope you're ready to begin to plan what projects you might want to embark on and who you will need to be on your QI team. Thank you so much for your time and attention. It's been my pleasure to host this three-part series on quality improvement for your practice. And at any time that I can help you embark upon the journey, please feel free to reach out to me.